Hi, everyone. Thank you for joining us today for our monthly Issues in Aging seminar hosted by the Friedman Center for Aging at the Institute for Public Health. We're really looking forward today to hearing more from Emily Somerville about her presentation, Medication Management in Older Adults. Emily is actually our Coppola Award winner for 2021. We give out 2 awards as part of our Friedman Lecture every year. And so Emily had won the award this year. And as part of that award, she also is willing to give us a presentation. So just a little bit about Emily before we get started. Emily Somerville is an instructor in occupational therapy and neurology in the School of Medicine here at Washington University in St. Louis. And right now she currently works in the Participation, Environment, and Performance Laboratory, otherwise known as PEOPLE, which aims to promote the participation of older adults with functional limitations in the home and community through the provision of intensive tailored home modification interventions. Sorry about my dog barking. Emily has a specific interest in helping older adults manage medications independently in the home and recently received funding to conduct a clinical trial studying the feasibility, acceptability, and preliminary efficacy of a tailored medication management intervention, which we're going to learn more about today. Emily is also the lead occupational therapy interventionist and implements study interventions with research participants in the various studies conducted in the lab. She trains occupational therapists in the community to deliver evidence-based interventions developed by people. And additionally, she is a study coordinator for a study that aims to investigate the efficacy and safety of a novel enhanced rehabilitation transition program to reduce environmental barriers and improve daily performance and community participation. So Emily, thank you for being with us today, and I will turn it over to you.
All right, thanks, Natalie. I am excited to share with you guys today about medication management and older adults. So as you likely know, we currently have about 54.1 million older adults living here in the United States. 77% of this group of older adults have 1 or more chronic health conditions, and 50% experience 2 or more. This 54 million older adult population makes up about 16% of our overall population here in the US, but they take a disproportionate amount of medications compared to the rest of the population. So they're taking about 34% of all prescription medications and 30% of all the over-the-counter medications. And of the older adults, about 50% are taking more than 5 medications every day, and that's known as polypharmacy. And polypharmacy is something that we want to think about and consider because it increases the risk of some problems with older adults. So you can have duplicate medications with polypharmacy, you can have adverse drug reactions, drug-drug interactions, and it increases the risk of geriatric syndromes. So that's things like falls, delirium, cognitive impairment, and functional decline. And one of the other big issues with polypharmacy is inappropriate medication. So 43% of older adults with polypharmacy are taking inappropriate medication. So those are things that older adults should not be taking because they can have such a bad impact on their health and overall ability to function. So inappropriate medications are specifically associated with an increased risk of higher healthcare costs, poorer functional status, decreased cognitive capacity, and also it's associated with difficulty managing medication. So looking more at medication management, about 40 to 75% of older adults who live in the community are actually not able to correctly manage their medications. And this can be problematic because it causes decreases in medication effectiveness, causes increases in adverse events and side effects from the medication. It increases the risk of institutionalization, and it can even cause death in people. It's also really costly for our society as a whole. It contributes to about $300 billion of healthcare costs every year for our country. And it also, medication management problems account for about 30 to 50% of all medication-related hospital admissions. So we have this big problem of inappropriate medications and a difficulty with managing medications for older adults. And so people have started to look at this and how can we actually help older adults better manage their medication? And so there are some interventions out there and the problem is that there are some issues with these interventions. And one of the biggest issues is that a lot of the interventions only focus on one class or type of medication. So they're looking specifically at, for example, how to increase an older adult's ability to manage their diabetes injectable medication. Or maybe they're looking at how do we help an older adult remember to take their inhalers or their blood pressure medicine. But as we just talked about, older adults are taking all kinds of different types of medication. So focusing just on one type is not always going to work for this population. One of the other things that happens with some of the current interventions that can be problematic is that they use a kind of one size fits all approach. So, everybody's given the same kind of pill sorter, or everybody's given the same pill bottles with a special lid on top, instead of actually looking at what are the specific difficulties that each individual person is having and how can we actually address those specific difficulties one by one. The other big issue that happens is that a lot of the interventions take place in the clinic. So if you look at these pictures, you can see the clinic, the picture on the left, is very different than a person's home, the picture on the right. So in the clinic, it's obviously, it's just a much more kind of clean, organized environment where the person just brings in their medication and maybe tells you how it's going or not going, versus in the home where it's much more complex. And so if we are only doing interventions in the clinic, we're completely missing the actual process of medication management in the home, and we cannot account for the complexity that the home environment brings to the table. So we wanted to kind of look at these interventions and look at the needs of older adults and develop our own intervention, which would hopefully address these big issues of inappropriate polypharmacy and difficulties with medication management for older adults. But kind of, we knew it had to be in a two-step process because we didn't want to, we didn't want to improve medication management to potentially inappropriate medications. So we thought, all right, well, first we've got to have a medication review where we're looking at medications and whether or not they're appropriate or not. And so that's, completely out of the scope of an OT to do that. So we knew it had to be multidisciplinary and involve a pharmacist and then also the prescribing physicians. And then when we were looking at how to actually improve their abilities to manage medication, we looked at some other interventions which are effective in improving just general activities of daily living for older adults. And those interventions are always specific and tailored to the individual needs of the person. And they involve providing modifications or strategies to the person to compensate for losses that functional losses that they might experience. And they're always delivered in the home. So we knew that we wanted those things to be components of this intervention. So we developed this tailored medication management intervention, or TIM, as we call it. So right now, as Natalie mentioned, we have some funding to do a single-blind randomized control trial to look at the feasibility, acceptability, and preliminary efficacy of this intervention. And so we are including about 30 people, those who are 65 and older, take 5 or more medications, and report a decreased adherence in medication on the medication adherence rating scale, or the MARS. Currently, we're excluding people with cognitive impairment. I think that's going to be a goal for later on down the road, is to include people who do have cognitive impairment. And then we're also excluding people who reside in an institutionalized setting. And for this trial, we recruited people from our local area agency on aging, and then just kind of word of mouth and flyers for people who, they're friends with or family members of some of those people. So as I mentioned before, these are kind of the main things we are looking at is feasibility and acceptability of the intervention first. And then we're also looking at the preliminary efficacy of it. So we can use this pilot study to eventually do a bigger bigger study. So for the feasibility and acceptability, we're looking at recruitment and retention. Do people actually want to participate in this intervention? And once they start participating, are they willing to complete it? We're looking at the dose, like how many minutes the intervention needs to be, how many treatment sessions, the safety of it. So like if they go to the emergency room or have a hospitalization, if they've had any falls or unplanned doctor visits. We also really want to understand the cost. So both the cost of the actual intervention itself, if there's things that we provide for people, what's the cost of that? And then also the pharmacist time and the OT time as well. And then for the preliminary efficacy, we're using two things. We have an assessment called the In-Home Medication Management Assessment, or HOME-RX, and it's got 3 different parts. The first part's looking at risk factors like whether or not they can afford their medication, if they're able to go get their refills, those kind of risk factors. And then the second part is compiling a medication list. And then the third part is actually having them perform their medication routine in the home, so we can actually see what problems they're having and identify barriers to their routine, to being independent in their routine. And then we're also looking at reducing potentially inappropriate medications, and the beers is the criteria that we're using for that. So like everybody and everything these days, we had all these grand plans of getting started. And then we, of course, came upon COVID and decided to pivot the whole thing to be delivered remotely. And so we had to develop and refine remote procedures. We figured, having the ability to do this intervention remotely, no matter what, COVID or not, would actually be a good thing. We can reach more people. Remote interventions have been shown to reduce interruptions in treatment. They can actually be more cost effective. So we thought, all right, we'll take this, we'll make lemonades out of lemon, or whatever that saying is. And so we developed and refined remote procedures. We tested them iteratively with some of our older adults. And so we ended up basically having to purchase new equipment. So we provided iPhones, because not a lot of people didn't have the technology to do the interventions remotely. And then we we came up with a harness to put the iPhone in, so that the person on the evaluator and the OT, the therapist on the other end of the Zoom, would be able to see from a first person perspective how the person did their medication management routine, versus setting up something like on a tripod where you're limited in more of what you can see, and it's stationary. So this way you can see the picture on the left, it's a harness that the person just wears over their shoulders, and the phone just clips into that. And then you can see the perspective in the picture on the right of what the therapist sees as they're going through the process. We did find through this process, and I know this probably isn't going to be surprising, that we needed to provide, either the person needed to have somebody who could help them with like getting onto Zoom, or we needed to provide a tech support person where their only job was to come in and get the equipment set up, and then go to another room or go sit back in their car, so that they're not interfering at all with the process, but that most people needed help with the setting up of the technology. So we kind of added that role to the study. So the overall intervention process, and I'm going to talk specifically about each of these things in a little more detail, but it's completed in kind of 4 main steps. So first, we've got an occupational therapist who completes the home assessment. Then the pharmacist does the review of the medication. And then the OT in the 3rd and 4th steps, they partner with the older adult and they use kind of a partnership decision-making process to figure out what hasn't worked for them in the past, and then what strategies and solutions might work for them going forward. And then we provide those things for them to improve medication management. And so those could be things like alarm clocks, pill sorters, specialized medication lists, etc. So all participants receive each of these same 4 steps, and then they get tailored to them individually based on their needs. So again, the first step is when the OT is completing the in-home the remote assessment, the person's in their home. And so they're looking at specific things like their personal abilities. So their ability to see, their ability to hear. And this is all just kind of done with using clinical judgment as they're working on the Zoom together. They're also looking at their ability to like manipulate small objects and their fine motor skills. And then they complete the home RX with them, which I mentioned before, the 3 different parts of looking at risk factors and making a medication list, and then having them performance and identifying the barriers and potential problems with medication management that the person's having. So what I want to do, and hopefully this will work, is I'm going to show you a little video of what it looks like to do the evaluation over Zoom. So first, a little bit about our friend Jack, who is going to be on the video. He is a 75-year-old white male. He lives by himself. His wife had recently just died last spring. So he's kind of in the process of still just figuring out what life looks like without her. He takes 15 medications. He has some years of graduate education, and he actually was retired from working here at WashU. And the reason I mention both of those things as being kind of important or interesting is that I feel like on paper, he comes across as as somebody who you would think kind of has it all together in terms of, you know, he's got education, he has a system for taking his medication. It's a little bit crazy, but it had worked for him for a while. So in just talking to him, it seems like he has it all figured out. But as you'll see, just a very short clip he has some difficulty actually remembering to take his medication. So we're going to give this a try, and hopefully you can hear it and see it.
And the Xarelto says it has to be taken with food.
Oh, okay.
I put it over here
Oh,
because that's where the dinner plate's going to end up.
okay.
So you would think with that standing in front of the dinner plate,
Yep.
you'd remember, right?
Right. You would think.
So the Xarelto then, when I fix my dinner plate, then I take this.
Okay.
Unless I'm thinking about, and the Xarelto says it has to be taken with food.
Oh, okay.
I put it over here
Oh,
because that's where the dinner plate's going to end up.
okay.
So you would think with that standing in front of the dinner plate,
Yep.
you'd remember, right?
Right. You would think.
So the Xarelto then, when I fix my dinner plate, then I take this.
Okay.
Unless I'm thinking about something else and walk away, eat dinner and come back. And then if I see this here, I know I haven't taken it.
Okay.
So then I'll take it. So it's either before you start eating or afterwards. They just say, I have no idea why it's on the biggest meal. I have no idea what the idea is behind it.
Okay.
So, but when I do take it, and when I've taken it out of the bottle and taken it and put the cap back on,
Yep.
it goes back upside down. So I remember the next morning that I took it.
Okay.
And my problem is just like the diltiazem. If I'm taking like in that afternoon, if I'm taking these, and if I take the bottle, let's say I took the vitamin D3.
Yep.
And I'm thinking about something, and I put that bottle down.
Oh.
I don't remember if I took it a lot of times. And most of the time I don't remember.
Okay.
And that's where the problem is, especially with the diltiazem. When I forget that, I don't dare take a second dose.
Right, because you
double
don't
dose
wanna,
myself.
Yep.
Yeah.
Right. Yep. Okay.
So I just have to wait till the next day when it's time to take it.
Yep. So that happens with the diltiazem and the
Yeah,
Xarelto.
and the Xarelto. Yeah.
All right. So that's just, again, just a quick glimpse into the assessment process where they're showing us. And so he would show us with all of his medications, how he takes them, and what problems that he has, and that kind of stuff. So After completing that evaluation, then we identified some things that were a problem and that were causing him to forget or not be able to take his medication, as independently as possible. One of the reasons, and he would be the first to admit he's a problem generator, not a problem solver. So he kind of has a tendency to make things actually almost a little bit more complicated than they need to be. So his system, while it was a system of flipping the bottle over, putting it back up in the cabinet, pulling it back out later in the day, et cetera. It worked for him for a while, but it was starting to get to the point where it wasn't as effective because he couldn't, he didn't know if he hadn't flipped it over or not, if he had actually taken the medicine, et cetera. And he didn't have any kind of cue, even just like an audible cue to remind him, okay, it's time for you to actually take your medicine. So he was missing those two, the Xarelto and the diltiazem, multiple times a week. And the other thing that was just kind of complicated for him was that he was taking medications kind of all throughout the day. So he starts his day very early at about 3:30 in the morning, and then he goes to bed at about 8:30 at night. And so he would just kind of take medication throughout the day as he remembered. So he was really taking it about 6 or 7 or 7 or 8 different times of day. And it didn't really need to necessarily be that way. So after the initial evaluation, then comes the step 2, which is the review from the pharmacist. So I sent over to her the results of everything, including the list and all the barriers that I saw from the evaluation. And she reviews the whole list. She uses a medication review kind of worksheet that she has. And first she'll call the older adult and talk through and kind of verify everything from the evaluation and provide education about, maybe why they're taking certain medications. In his case, he said he didn't know why he had to take it with food. And so she would provide education about that. And then she will also have specific recommendations for things like deprescribing inappropriate medications, or like in his case, things like combining pills so that you don't have to be taking it throughout the day and remembering multiple times a day. So again, she's looking at things like drug-drug interactions, routine simplification, inappropriate medications, and that kind of stuff. So she creates a worksheet, and that gets sent straight to all the prescribing physicians. So whichever physicians are prescribing the medications, and so then they need to be up to date on whatever the recommendations are. They all get a fax and describing what recommendations are made by the pharmacist. And then they have this spot, as you can see on the bottom, where they get to say, I agree. And so, they'll follow up. Nothing else needs to happen. They disagree, and they're not going to, implement the change. Or perhaps maybe they have a question, they want to talk about it a little bit more, and then just any comments that they need or want to make. So that goes to the doctor, and then hopefully gets faxed back with approval, disapproval, whatever needs to happen. And then the pharmacist relays any changes to both the older adult and the OT, so that when the OT goes forward with the next steps of the intervention, we've got all the updated lists, doctor's approval, et cetera. So that brings us to the 3rd and 4th steps of the intervention, which is where, again, the OT is going to work with the older adult to figure out how to make their medication routine, how to make them as independent as possible in their routine, and what supports they need or strategies they need. Again, it could be something like a different pill sorter, a medication list that's color-coded by day, an alarm clock, better lighting, a better place to set up their medication, whatever is going to solve those barriers that were identified at the initial evaluation. So we've got another video of our friend Jack, and this is filmed recently, actually. So it's not from the Zoom perspective, but it'll hopefully make it easier to see kind of what we ended up doing with him, which was he didn't have any actually inappropriate medications. His biggest thing was helping to simplify his whole routine so that he could take medications at 4 times a day instead of throughout the course of the day, 7 or 8 different times. We had to work through a couple of different types of pill sorters. He had one actually from his wife that he didn't like, and it had kind of turned him off to pill sorters in general, which was why he wasn't using one originally and doing his flipping over of the bottle routine. So what we found out that he wanted, and he just didn't know existed, was a pill sorter where that came out by day instead of by like the entire week. So we ended up getting him a pill sorter that the whole 4 times a day came out, and then we color coded and put labels on there for the time of day he was supposed to take it, and then little dots that correspond with his list. So like the yellow dot on the top corresponds with the line on the list for the medication that goes in that compartment, and then the green dot corresponds with the green lines on the list, the red, and then the blue. They all correspond. So we're gonna watch him do a little bit of his routine afterwards.
Then, so we checked off the tamsulosin. No, I didn't. So, and this does keep me on track, because sometimes if I get distracted, it's so easy to forget. Oh, you're the ones that doing all the colors. I think we changed the colors on here too.
We did.
I was having trouble with the colors.
Yep, I think you're right.
Because I am colorblind to some things, if not many things. Okay, so that's the vitamin C. Total tasting tablets. Guard, which I can't take until 30 minutes after breakfast. So that's about the time I brush my teeth.
Yes.
So you gave me a little card
That's
that says take IB Guard. And there's one on my mirror. And then there's a little box on my dresser that has the IB Guard, little packet that has a bunch of the IB Guards in it.
Yep.
So that's in there too. So because I open that every day to wind a watch, it's in there.
Right.
So I open that in the morning when I get up.
So you've got 2 places to remind you to take it.
So,
Perfect.
so it's on the list, but there's another way to take care of making sure I have in front of me.
Yep.
Okay, Xarelto is one of the more difficult ones. So Xarelto. And the final one is going to be the gabapentin. Tomorrow morning when I take the first pill, I'll take this out.
Yep.
And I'll set it on the counter.
You'll be good to go.
I'm good to go. And then when I'm done through breakfast, I'll set it back on top of there so it's out of my way.
Yep. And then you can see which.
And I can't miss it because I got my alarm.
Yep.
So, I mean, it's really, that really does help. So I mean,
That's great.
Can't miss it.
Perfect. All right, so that's his new routine with an alarm clock, a medication list, a new sorter, and then that little card he was talking about reminds him to take one medication that doesn't go in his sorter, but because he has to take it later after food. So here's just a couple other examples. These are, again, this is kind of back to the Zoom perspective. So more examples of what we've done with people. So this picture on the left is somebody who was having difficulty remembering whether or not they'd taken their diabetes medicine, whether they'd done the injection or not, and then how long it had been since they had done their injection. So we got him a timer lid. So it is a lid that fits on top of the pen. And as soon as you take it off, it resets. And so then you know that you've taken it off and hopefully injected it. And then you can also tell how long it's been since your last, since the last time you did it. And then also the therapist helped him set multiple alarms on his phone to remind him to take it throughout the different times of day when he was supposed to be taking his insulin. Another example was from somebody who, again, had a pill sorter, but it wasn't working for him. So he takes medication twice a day and had a pill sorter that was for 4 times a day. And the labels had worn off, so he couldn't, really see what time of day it was supposed to be. And he there wasn't actually room for all of the pills in each of the compartments. So he would put extra pills he was supposed to be taking but wouldn't fit, he would put them in another row, but then he would often forget to take those at the time of day he was supposed to be taking them with the rest of the pills. So we got him a bigger sorter that was just morning and evening, the 2 times of day that he needed to be taking his medication. And it was big enough for all of the pills to fit in one, and it had easier like push tabs, which were easier for it to pop up. And they'd come apart, so he could put the morning ones they come apart by row, opposite of the other guy. So they come apart by row. So all of his morning pills would sit at his breakfast table for when he ate breakfast and took them in the morning. And then the evening ones would sit on his bedside table where he could take them at night. And Becky in the picture, that's the therapist who's training him on how to do how to use each of these new strategies over Zoom. So we've got some just overall examples of what we've done with people. So the main pharmacist recommendations are, number one, just deprescribing inappropriate medications, reducing pill burden. So a lot of people, and this seems to be specific to vitamins, where they're taking like 10 different random vitamins. And so sometimes she'll, if it's appropriate, provide education and about maybe taking a multivitamin, just so they're only taking one instead of 10. And then that makes it easier for them to then be more compliant with their prescription medications. So she also provides a lot of education about like why it's important to take certain medicine at specific times of day, or a lot of times the reason for their medications, or why they have to take it with food. And then of course, some drug interactions for people. So like there was somebody who was taking a leave while they're also taking a prescription blood thinner. So she would provide education on what to do instead so that there wouldn't be those interactions. And then some of our primary OT recommendations and things that were implemented are like that customized medication list. This is actually Jack's list here, where it's actually listed by time of day, which makes it easier for a lot of people. Instead of just the medication list with the instructions, it's listed out by time of day. And then whatever kind of pill sorter might actually work for them, and different kinds of alarm clocks, whether it's an alarm clock, like an external alarm clock, like this one, where you can set multiple alarms a day, shown in the picture, versus a cell phone if they have one and they want to put the alarms on their cell phone. So we don't have any of the preliminary efficacy data yet, because that's all still coming in right now. So you'll have to stay tuned for another month or so when we'll get to see how it's looking in terms of actually improving medication management ability. But we've got some other interesting kind of process outcome data to look at right now. So overall, though, this is our whole group. There's about 30 of them, a little over 30 total. So both groups, they're about 72, 73 years old. About half are female, half are Black, and have just a little bit over a high school education. Most of them live alone and take about a total of 22 for the treatment group and 19 medications for the control group. 13 or 12 of which are actual prescription medications. And both have had about 5 falls in the last year. So first, when we're looking at that, what we talked about earlier, like the feasibility and acceptability. So looking at the retention, and this is just in the treatment group. And we have one person who's not done yet. So this is looking at the 15 people who are done. So about 87% are still going strong, going through the study and getting ready for their final follow-up. So some interesting things here when we look at the minutes of treatment and the minutes of the evaluation. So there's some pretty big standard deviations for some of them. So the evaluation itself takes about 2 hours, and over Zoom, that's a pretty long time. And for some people, the standard deviation is about 50. So it can range a fair amount. And the treatment, again, over Zoom is a little bit over an hour with a range, or the standard deviation is about 45 minutes. So the pharmacy review, where just the pharmacist is reviewing it herself, is taking just about 20 minutes. And then when she's calling to educate and talk to the people, that's about 35 minutes total. One thing that is exciting is that it's actually not super expensive. So when we're providing things like the pill sorters or the alarm clocks, it's just about $46 total to provide these things for our older adults. And a little bit over half of our treatment group required 2 visits, 2 actual treatment visits, some only required 1. And it's been taking about 2 weeks to complete the treatment process. There are some who, again, are outliers. And I think what we're going to do do is kind of dial down a little bit deeper in the data to figure out who are the people who are taking longer, and why is it taking longer. And so then we can, when it comes to implementation time of this intervention, we can really have a better understanding for the therapists and pharmacists and physicians who would be involved in this process. You know, they can really kind of have a better understanding of how it's going to work with the older adults. So about half of them were taking inappropriate medications, which is pretty consistent with what we know about the prevalence of that with older adults. And then the last thing I want to highlight here is the approval by doctors. So that's when we would fax that pharmacy review sheet to the doctors. 6 of them said, yep, totally agree with your recommendations, go ahead. 1 said, nope, don't agree. 5 did not respond at all. And then 4 had no approval was necessary, like if it was just, again, kind of things that the was within the scope of the pharmacist's recommendations, like changing the time of day. They were taking it in the morning when really they should have been taking it at night. So that's something I'm going to talk about in a minute of ways that we can work to improve the intervention. And then just specifically related to the Zoom call outcomes. So most of them did have difficulty setting up the Zoom call, which I think is not surprising. And this is for both of the groups. And most of them required help during either the setting up or out the call. Like sometimes the camera would get accidentally turned off. So we asked people, are we measured on a scale of 0 to 4? 0 meaning they don't need any help, and a 4 would be like we would have to hand over hand help them throughout the process. And everybody was kind of around the score, around the average of a 2, meaning that they needed help with between 25 and 50% of the tasks related to Zoom. So again, things like making sure that the camera didn't get turned off or that they could hear, or whatever. We also kind of clinically thought, okay, how many of these people do we think could actually complete the evaluation and intervention process on their own versus how many would need a caregiver, a friend, a family member to help them. And only about 30% actually would have that ability to do it on their own. And same, about 30% would have the ability or own the technology to do it, again, to be able to do it on their own. But I think most importantly to highlight from here is this bottom line, which is their self-rated, the older adult self-rated comfort with doing it over Zoom. So we asked them on a scale of 1 to 10, 1 meaning, I'm not comfortable at all, a 10 meaning I'm totally comfortable. And they were kind of right in the middle of definitely not totally uncomfortable, but definitely not totally comfortable. So that kind of leads us into our lessons learned so far. And we're going to have some specific considerations for how to continue to make this remote delivery process work for people, how to make sure that they're comfortable, who it actually would be appropriate for, so like if you have somebody who's hard of hearing, or maybe doesn't see very well, or has maybe they've had a stroke and so they have fine motor difficulties with one of their hands. How can we make it possible for the most amount of people? And are we going to, maybe it's just that some of those people are going to need to have a caregiver or family or friend to help them. We also are realizing with the remote thing over Zoom that you can only see what you can only see, which is kind of obvious, but also really important. So we've got the angle of the camera, and we can ask them, and often do ask them to move the angle of the camera around, but that's all we can see. So, whatever's outside of the view of the camera, like if there's 4 medication bottles sitting on a side buffet that I can't see from my end of the Zoom call, then that's a problem. So we're realizing that there are, and we've started compiling a list of questions that are going to just kind of become part of the process to ask them things like, all right, are there other pill bottles around, or again, that maybe if there's a caregiver or a friend involved, that we would be able to ask them, do you see any other pill bottles laying around? Can you see if there's any pills on the floor? That kind of stuff. So just, again, figuring out who this is going to work for, and how we could make it work even better to do it remotely. And related to that, we also are going to tailor or see if there's ways that we can tailor the length and the number of visits for specific populations. So kind of like I said before, there are some visits that were taking a lot longer. So we're going to look and see, you know, again, are those people that maybe have a lot more medications to take? Are they people who have just much more involved or more complex physical conditions that make it harder for them to participate? And how can we make this work for them as well? And then I think the other important piece is how can we improve communication between the pharmacist and with physicians? So right now it's great because we've got a pharmacist as a member of our research team, and she's easy to access and, you know, can do the reviews. But what happens when we take this out to the community level and we've got, you know, their pharmacist at Walgreens or their pharmacist at Gateway, or how is it going to work with getting them to do the medication review, communicating that back with us and communicating with the physicians? And we did have, I think it was 4 physicians who we did not hear back from. So obviously we need to tweak how we approach, and, you know, maybe there's better ways that we can communicate with the physicians to make it easier for them to respond. We would fax to them the recommendations multiple times, and then Banaz, our pharmacist, would follow up over the phone about 4 or 5 times to get a response, hopefully, and sometimes again didn't. And so we're trying to figure out what would be the best way that we can improve that communication to make it easier for physicians to respond. So those are kind of some of our specific lessons learned. And then we're in the process of tweaking things to do a remote versus in-person equivalency trial. So now we've got the people who are in the control group who didn't receive the intervention at all. And so we are going to convert them over to in-person. And so then that way we can look and see whether did the remote intervention work at all. So remote versus control. And then we're going to have our in-person people, so where we deliver the exact same thing, we just do it in person. And so we'll be able to compare the two, the in-person versus remote, for equivalency and see if in fact they are equivalent. And then that will give us some better directions for going forward when we want to eventually bring this up to a larger scale effectiveness trial. Perhaps we would do both remote and in-person if they are equivalent, or maybe we drop one, maybe we tweak one. We'll just kind of have to see again. So you'll just have to stay tuned to see how that all pans out here in a little while. That's going to be coming up in the next months. So that is all I have today. I am ready for any questions, I think. And then also my contact information, if anybody wants to contact me afterwards, you're more than welcome to.
All right, thank you, Emily. Very fascinating presentation. So we do have a couple of questions so far. If others have questions, please feel free to put those in the Q&A, which again can be found at the main menu, the main Zoom menu at the bottom of your screen. Or if you'd like, you can always put them in the chat as well. So I'm going to go to the ones in the chat real quick. They're kind of related and also related to one that we had in the Q&A. Specifically around cognitive impairment and how you are assessing for that, and whether or not if Zoom was related to that and maybe being a good assessment of cognitive function.
So we do the short blasted test over the phone first to we administer it over the phone as part of the screening process to figure out whether or not they would qualify for the study. So that was done over the phone, no Zoom involved in that. And that's a pretty standard way that you can administer it. And so anybody who scored, I think it was anybody who, I think 10, or worse, would anybody who had a cognitive impairment indicated by the short blasted would be excluded from the study. So we do want to eventually include people with cognitive impairment because that's a big portion of the older adults, older adult population. But we did it over the phone to start with for this, so that Zoom wouldn't be a complicating factor in that screening process.
Another question we had, do you address the issue of substance misuse in older?
That is a great question. No, but I think that would be definitely something that we need to consider, because there's a lot of people with substance misuse and abuse. So and it plays a big part in their ability to do any task throughout the day, but also related to medication management for sure. So we stuck to the legal prescribed medications, and we did not really go into any of the other into any of the other areas. I'm trying to remember. I don't. For a couple of our other studies, we do ask them about a history of substance abuse or current or history of substance abuse, and we did not for this one. So maybe that would be something definitely to consider.
All right. And next question. Did the pharmacist have access to the patient's medical record and is accessing or assessing appropriateness of medications? Because using only Beer's criteria identifies only 10% of inappropriate medications when assessing in the context of the medical record.
Yeah, that's a great question. It kind of depended on the person, whether or not they were, they all gave us access to their medical records, but our permission to access them, but depending on whether or not they were in our system or not. So that's where we would rely heavily on the doctor. Like, she would make the recommendation and then ask specifically for the doctor to further review their medications for anything that was inappropriate, because she didn't have access to all that information for some people. So and I think that's definitely something that we need to work on figuring out how to make that process better, because I do think that was definitely a weakness, is that she didn't have that for everybody. And so again, then we had to rely on the physician for that, and some would be better about follow through than others. So when she didn't have all the information that she needed to make that call, she would specifically make a note of that and ask the doctor for that information, or for them. She would say, here's what I'm seeing and what I'm thinking. Can you please confirm, deny, whatever.
All right. And then what is the cost of the intervention? Your table showed $46.95, but also showed the evaluation. The interventions took about 4 hours of OT pharmacist time.
Yeah. So thank you. I need to clarify that. So the cost was looking at just the cost of the actual, like, whatever equipment was purchased for them. So like the pill sorter, a magnifying glass, a alarm clock, whatever. So that's where the $50 came in. Thank you for clarifying that. The time, which is what we will do further analysis on, is looking at how much billable OT time, and the pharmacy review is a billable service through Medicare. So we will look at adding the specific pharmacy cost and OT cost into it. We will do that definitely eventually, but that $45 was specific to the equipment, if you want to call it that we got for the older adult.
And then how about, do you recommend any particular brand of voice activated or alarm dispensing system for those specifically with dementia who are living independently? Added on to the comment here is there data to suggest these work better than the family putting out a week's worth of meds at a time and calling for daily reminders?
I don't know of any specific data. I'm sure it's probably out there. They do have those automatic dispensing systems with the reminders. They are super expensive. And they actually require a fair amount of setting up, and they don't always, you can't always set them for like multiple times of day. They have some limitations. So I think it would be definitely on a case-by-case basis as to whether or not it would work better for the person. It'll depend on how many medications they're taking, how many times of day they're taking their medications. Some of them actually have a monthly subscription fee. So you buy it initially you buy the equipment, but then you have to pay $30 or $40 a month for that continued service. So I've seen them work for people, definitely. but whether or not, it's hard to say, and that's probably not a helpful answer, but it depends on the person and their specific situation, whether or not it's going to be easier or better than maybe a family member setting it up or checking in with them on a regular basis.
I think Natalie is having a little bit of some technical issues here. Let's see if anything has not been asked. Actually, I'm going to open it up so that participants can raise their hand and I can unmute them if they would like to ask a question. If you have a question that hasn't been asked or you would like to ask a question yourself, just raise your hand and I can unmute you. Okay, here we go. We have Eric Lenz. Go ahead.
Hi, can you hear me?
Yep.
Yes.
Okay. Thanks, Emily. It was a really enjoyable talk and really important issue. My question is about antidepressants, which are sort of on the JAGS Beers Journal of the American Geriatric Society Beers list, although somewhat vaguely about them. How do you and others treat antidepressants that older adults are taking with respect to, and frankly, a lot of other psychotropic medications that are with respect to making deprescribing recommendations?
That is a fantastic question. So I can give you an example of somebody that we saw specifically in the study. Actually, she's the one that's taking a while, and it's for this exact reason. So she's currently on 6 different antidepressant medications and is still, they're not working, basically. She's definitely still would be considered depressed on any of the assessments. So most of them show up on as inappropriate medications. So Banaz, the pharmacist, has been working closely with her psychiatrist, and what they actually ended up doing is ordering a pharmacogenomics test to be done with her to try to figure out what medications would actually be appropriate given her genetic makeup, so that they would be able to, work actually more effectively for her. And so then potentially we'll wean her off of some of the 6 medications that she is on, and then hopefully reduce and find some more like less number of medications, but more effective based on her genetic makeup. So I think it's something that is definitely a big concern for a lot of older adults, and requires probably a lot more collaboration, I think, between the psychiatrist and the pharmacist, and then eventually the OT down the road, to figure out, because, the pharmacist was very hesitant to take her off of any medications, even if they were inappropriate, because she didn't want any, super negative outcomes of her depression. So I'm not really sure if that answers your question, other than maybe just to confirm that, yes, it is a very significant issue, and they're trying to approach it, I guess, from the side of doing pharmacogenomics and figuring out maybe there's something that's actually going to be more effective for her, so that she doesn't have to be taking 6 different medications.
That's great. I don't know if you can still hear me.
Yeah.
Oh, okay. That's great. I hopefully they'll turn it off when the meeting is over, so you don't hear my next meeting. That sounds great. It sounds like there's a bit of it, like a step care built-in component to your intervention, where the more complex cases like that get more care rather than a one-size-fits-all one, which is great.
Yeah, I think you're absolutely right. And that's what I really want to start to look at more, again, with like the number of treatment minutes that people needed, the number of visits that people need. And just like you said, maybe they're going to need a couple extra referrals, or, but I think the issue I see is how this is going to work in real life. And again, when we're working with like a community pharmacist, or just somebody maybe who's not as dedicated you know, she's paid on the grant to do this. So how we're going to make that more work and implement it in a more in the real world. We'll definitely need to figure out how we can use that kind of stepwise approach, like you said.
Thank you.
But you can give me all the suggestions that you have. I would love it.
I mean, I just saw 2 patients like that today, and it's pretty overwhelming, even for the
absolutely
people with expertise in the area.
Yeah.
All right, thank you.